Ladies and gentlemen, good morning. I'm Johnny Liaw from National Taiwan University and also from Taiwan Association of Orthodontics. I'm much honored to be here as a part of this fantastic conference. Taiwan is a small, beautiful island surrounded by China, Korea, Philippines, and Japan. The city I stay is Taipei, which is the capital of Taiwan, and also where the highest building of Taiwan, the Taipei 101, is located. As an orthodontist, the Taipei 101 looks like a mini school to me. I hope I can convince you the value of tests in the recycling orthodontics. I'd like to take this opportunity to extend my most sincere gratitude to the organizing committee for their kind invitation. Before I start my talk, I'd like to declare no financial conflicts in the following presentation. The topic I'm going to share is recycling orthodontics optimized with tests, interdisciplinary treatment, and enhanced auto-transplantation protocol. Tooth transplantation was started around 500 years ago. There were sporadic reports in the past few centuries. The reason why it is uncommon might be due to many of the dentists are not fully aware of the procedure, and there is always a risk of failure and lack of commercial interest. But nowadays, the success rate is very high with the enhanced techniques. So it deserves our attention to consider auto-transplantation as one of the treatment alternatives, especially when extraction is considered in the orthodontic treatment. That's why I call it a recycling orthodontics, which could be optimized with tests, interdisciplinary treatment, and enhanced protocol of auto-transplantation. I plan to go through definition, rationale, indication, and share you my SOP with the emphasis on prognosis and success rates. In the end, I'd like to discuss the possible occlusal scheme and highlight the interdisciplinary treatment. Tooth auto-transplantation was defined as a procedure to extract a tooth from one location and replant it in a different location in the same patient. In comparison with the dental implant, the auto-transplant is kind of a biological replacement with normal PDL. So it is possible to move the transplant with the orthodontic force, and it may erupt with neighboring teeth. So with the PDL, it is possible to create alveolable, and it tends to have normal gingival papilla. So it could be provide a viable alternative to implant prosthesis, and it is cost effective. The major disadvantage may include more surgical involvement and risk of failure. It can be classified according to where the PDL remained. With the pre-existing socket, the PDL may remain on the root surface of the donor tooth and the socket wall at the recipient site. Without the pre-existing socket, the only source of the PDL only remained on the root surface of the donor. And this makes difference in the success rate. With the pre-existing socket, the success rate could be as high as 95%, but without a socket, the success rate would be down to 60%. Age is another important factor for success rate. Without a pre-existing socket, the success rate could be 75% in patients under age 40, while it is down to 49% in the patient over age 40. The stage of root development is another factor for prognosis. In the developing tooth with open apex, pulp healing is possible, but root canal treatment is always required for auto-transplant with closed apex. So the prognosis is the greatest in immature tooth with open apex, and the root development around 2/3 to 4/5. And additionally, auto-transplant of single roots got the better prognosis because of the easier adaptation into the recipient socket and better quality of root canal treatment. For the procedure, after flap reflection, it starts with socket preparation with high-speed surgical burr and followed by drill kits for dental implants. After that, the donor tooth should be extracted as traumatically as possible to preserve the PDL cells. Then, trial fitting into the recipient socket. 3D print-out replica could be used to minimize the extraoral time and preserve the PDL cells. Then, stabilize the transplant with the sutures or arch wire, then cover with periodontal dressing. Root canal treatment should be started within 2 weeks after transplantation to avoid root resorption. The definition of success was defined by no signs of attachment loss, root resorption, or ankylosis. Otherwise, it was a failure. As for indications, of course, we need a recipient site where spaces may remain after orthodontic treatment, and a donor tooth which is planned to extract for orthodontic treatment. So let's start with my first case. This lady complained of bimaxillary protrusion, and she got her upper left premolars missing, 2 premolars missing. To reduce protrusion, we plan to extract 1 premolar in each quadrant, except the upper left, where no premolar to extract anymore. With 1 premolar space closure in each quadrant, we may need a dental implant at upper left in the end. But if we can include auto-transplantation in this case, we may finish this case without a dental implant. So after 4 mouth bonding, we also bound the possible candidate of the donor tooth to make them loosen, and which is very predictable for a traumatic extraction. So in the 2nd month, we start the auto-transplantation from lower right 2nd premolar to upper left 2nd premolar. The reason for this choice of the lower right 2nd premolar was it was single-rooted, which makes the prognosis much better. We can easily identify the roots, the number of the roots from the CBCT image. After that, we start with socket preparation. Then we may use the 3D print-out replica for trial fitting. Then stabilize the transplant with the brackets and the arch wire, soft arch wire. It was suggested by Tokyo Medical Dental University in this article. They used the improved super elastic tight arch wire, which is also known as the LH arch wire in commercial name. It was named after low hysteresis, which is characteristic of vibrational force absorption. This will greatly reduce the occlusal force transmission, and in turn, it will reduce the risk of the ankylosis. So it was concluded that early application of orthodontic force may improve the success rate of the tooth auto-transplantation. After transplantation, the root canal treatment should be started within 2 weeks to avoid external root resorption caused by endotoxin released from the necrotic pulp. As for the start of tooth movement, according to this histological study done by Tokyo Dental College, we need to wait 2 months interval for the periodontal reattachment. So after that, we start the space closure as usual. You can see the space closure proceeded smoothly, and we can close all the spaces. And here is the treatment comparison. The facial profile was beautifully reduced, and the occlusion was good. The cephalometric superposition showed very typical correction of the bimagnetic protrusion. And here is the OPG before and after. The periapical film looks pretty good in terms of roots, available, and the PDL. I follow the protocol written in this book by Dr. Tsukiboshi, but I modified the procedure by stabilizing the transplant with the bracket and arch wire. Since I'm an orthodontist, I myself prefer to stabilize the transplant with the arch wire instead of suturing. For adolescent patients with protrusion and badly decayed molars at the upper left and lower right first molar, we may prefer to extract these teeth with bad prognosis. To balance the extraction spaces and to correct the protrusion, we plan to extract the upper right and lower left second premolars, then close all the spaces. But we also plan an auto-transplantation from lower left second premolar to the lower right first molar spaces, then close all the space. So after full bonding, we proceeded to close all the spaces, but when it comes to a premolar size at the lower right first molar, it's time for the auto-transplantation. After transplantation, we use the biturbos, razors to prevent the occlusal trauma. And you may notice the dental midline was off and the interdentation was not good. But we started to close all the spaces, and you may see the dental midline was corrected, the interdentation were improved with the help of the mini screw on the top. And here is the treatment comparison. The facial profile looks good, and the occlusion looks fine. Although there were 3 premolars at the lower right, but the interdentation was pretty good. Here is the OPG before and after. And this is the periapical film. All looks good. So I think the recycling orthodontics with the tooth auto-transplantation can provide a viable treatment alternative for orthodontic treatment, especially for the adolescent patients who are not so appropriate candidates for dental implants. Without the tooth auto-transplantation, we may need a dental implant at the lower right first molar space. But for this adolescent patient, she is too young to receive a dental implant. If we decided to wait, it might be challenging to keep the space, and it is very difficult to keep the alveolar ridge. If we decided to close all the spaces, we may need a mini implant anchorage to protract the lower right segment to make the dental midline coincident. So I think this is a good strategy to make the thing simple. After the experience in adolescent patient, I try the same approach in this adult patient. Protrusion, upper right first premolar, not so good. So we decided to extract upper bilateral premolars and lower right second premolar because there has been a missing at lower left molar, first molar. And we also plan an auto-transplant from lower right second premolar to lower left first molar. So here we can see the transplantation, and we may notice the dental midline was off now. And after transplantation, we start the space closure and finish like this. The profile was greatly improved and the occlusion looks good, except there were 3 premolars at lower left, but the interdentation still looked very good. Here is the OPG before and after, and also periapical film. All look good. And here is another case. We can see multiple congenital missing in the lower arch. But upper arch crowding and moderate protrusion were noted. So we plan to extract upper premolars, and we may consider using the upper second premolar extraction and transplant them to replace the lower right second premolar and the second auto-transplantation for the lower left canine. And I also rotate the second auto-transplant to mimic the canine morphology. After the transplantation, we started the space closure as usual. Then here is the treatment comparison. The facial profile was good, and the interdentation, actually on the right side, a little bit less than ideal. But the dental midline is okay. But this patient was pretty happy to finish her treatment with so many congenital missing without a dental implant. Here is the OPG before and after, and also the periapical film of the 2 auto-transplants. Even more congenital missing of 6 premolars. Maybe we can consider close 1 premolar space in each quadrant. But in the end, we may still need 2 dental implants on the top. But luckily, I saw the possibility of the wisdom teeth. So I start the treatment by closing all the spaces. When we close most of the spaces, I start the auto-transplantation from the wisdom teeth to the upper premolars. After transplantation, you may see it looks pretty good because it seems even though we need to reduce the crown portion of the wisdom teeth a little bit to fit into the premolar space, but we can finish this case without a dental implant. So, orthodontic space closure and 2 auto-transplant successfully finished this case without a dental implant. Here we have a lady complaining of protrusion, and she got multiple missing in the lower arch in the posterior area. Because of the protrusion, we plan to extract 2 upper premolars and maximal retraction. So I decided to use the extracted upper second premolars to place them in the lower edentulous area. Like this, the first auto-transplant. And here, the second auto-transplant. After that, we started to close all the spaces except the lower left. There would be 1 space left to receive a dental implant. So when the space management is ready, we start the dental implant insertion, connective tissue graft, and provisional prosthesis one by one, and close all the spaces. Here we near the end. And here is the treatment comparison. The facial profile was improved, but the occlusion, you may see, look a little bit strange. In the lower arch, we got totally 7 premolars, but the occlusion-wise is still okay. Here is the OPG before and after. It was my great pleasure to present in AAO annual session in San Francisco in 2015, entitled with Tough Case Made Easy with Tests and Interdisciplinary Treatment. I shared this case, this 4 months rehabilitation with 2 auto-transplant and 1 dental implant. Here you can see these 2 auto-transplant and 1 dental implant there. Here are the parietal films of these 2 auto-transplants. The cephalometric superposition showed pretty good mandibular response and the maximal retraction to obtain the facial profile reduction. The upper incisors were well intruded to correct the gummy smile. You may see the occlusal plane was moved upward to rotate the mandible counterclockwise to improve the chin projection. I got the comment as good job, but I got even more question about the stability. So let's see how she looked like after 10 years. The occlusion looks pretty stable, and these 2 auto-transplant look very fine. So we published this case in AJODO. I think that is a good example for the beauty of interdisciplinary treatment. Remember the first case I mentioned today? And this is how she looked like after 11 years follow-up. Everything looks good. And here are the parietal film of the transplant after 11 years. The PDL, the alveolar bone, and the root look still very good. So as long as we can understand the biological principle and follow the protocol, fulfill the requirements, I think the success of auto-transplantation is pretty good. I compared my statistics with Dr. Tsukiboshi. I think it looks comparable, especially the cases without socket. Because in Dr. Tsukiboshi's data, it's around 60%. But for my statistics, it looks a little bit improved. But I'm not saying that my protocol works better, but I try to draw your attention to this, the significant difference of the success rate of premolars and the molars. You may see here around 90% versus 70%, which I think that is significantly. A recent paper also supports the transplantation of premolars with developing or fully developed roots is a predictable treatment modality. So here is the SOP I just go through, but I like to emphasize the possible occlusal scheme. Except the extracted or non-extracted molar class 1, please, we are also familiar to the single arch extraction occlusal scheme at 40 molar class 2 or 4 molar class 3. But with auto-transplantation, you may see 3 premolars in one quadrant. But if you remember the last case, we may have 3 premolar or 4 premolars in the low quadrant, which makes one upper premolars may match well with 1, 2, 3, or 4 premolars. With this idea, you may make the treatment plan according to your imagination. The next point I like to emphasize is the recipient site space management with TAS. If the desired recipient space was occupied by adjacent teeth, we need to make the space before transplantation. You will find the you may find the TAS very helpful in space management. And after transplantation, we can fully digitalize the dentition to correct the class 2 also. And also improve the dental midline, improve the interdentation with the help of TAS. Of course, also the profile reduction. To optimize the recycling orthodontics with tooth auto-transplantation, I hope you may appreciate the collaboration among various specialists, including orthodontist, endodontist, periodontist, prosthodontist, and implantologist. In conclusion, tooth auto-transplantation is a viable treatment alternative in orthodontic treatment. Recycling orthodontics is possible not only in adolescent patients, but also in adult patients. For diagnosis and treatment plan, we need to know the positive factors of prognosis, including young age, open apex, pre-existing socket, and single roots. To improve the success rate, TAS are very helpful for recipient site space management. If possible, root canal treatment can be completed before transplantation. Orthodontic leveling is very predictable to ensure a traumatic extraction. 3D replica can help to preserve PDL and minimize the actual time. Soft wire fixation is good for initial stability. Versatile occlusal scheme may free your imagination on treatment plan. The last but not the least, I'd like to highlight the interdisciplinary treatment as the key to success of auto-transplantation. Thank you for your kind attention, and if you are interested for the references I mentioned in the presentation, you may scan the QR code and leave your email address there. I will send it to you very soon. And please take a moment for the evaluation. Thank you. Thank you so much.